Go ahead.
Hi, I'm Tom Lynch. Two things. Today I'm delighted to be joined by Luis Ticona and Brian Yoon. Luis is with the MGPO and Brian is here in the emergency room. Brian, what's the hospital at home program?
Yeah, so traditionally when a patient comes to the emergency department, we're trying to figure out what's the best way to take care of a patient. And traditionally, after we acutely stabilize the patient, we either send them home or the observation unit or the hospital. And what we realized is it shouldn't be within those three treatment options, that there's this fourth option, because when patients are admitted to the hospital, there's a long wait. The median length of stay is 9 hours, and it's not unheard of for a patient to wait 1 to 2 days for a bed, and that's where the home hospital enters.
But Luis, what's the difference between just a discharge with, let's say, VNA help and the hospital at home?
So the hospital at home is a pretty intensive set of services. It actually includes a nurse practitioner, and a physician, as we designed the pilot. It's typically 2 to 3 visits a day for a period of time of about 3 to 4 days. Access to infusion equipment, access to oxygen in the home, access to point-of-care labs and lab draws. So we really try to replicate as close as possible a higher acuity of level of care, much like the hospital. And even to daily progress notes, to a discharge summary, to communication with primary care, we really take that level of care way, way up.
And so, are there people who this would not be applicable for? I would think anyone who needs monitoring or anyone who could be clinically unstable, I imagine, wouldn't necessarily do well with this. Does the patient have to have a strong family infrastructure to make this work?
That's a great question.
Yeah, that was part of our design. So we always interface with the family to ensure that this was good for them. But in particular, we needed somebody to be in the home with the patients. Some families actually had access to caregivers that they paid for, and that was adequate. Some folks had a niece or a daughter that would stay there and would be able to monitor people. But in terms of the clinical exclusion, people that needed telemetry or had kind of arrhythmias, those were kind of clinical exclusions that we would take out.
And Luis, this is part of the population health management program of the MGPO and the MGH. What's the purpose? Is the purpose to save money? Is the purpose to do better care, more appropriate care? What are the goals you're looking at?
I think the beauty of a program like this is that it achieves all of those goals. It really gets at the core of value. So the idea is trying to find the most appropriate amount of care at a cost that is favorable to the health system and that actually promotes satisfaction for the patient. So a lot of research actually shows, and I don't think it's too contentious to say, that people really prefer to be at home to get some of this care if they need antibiotics or oxygen. So patients really like it. Our system feels like it is cheaper care in terms of engaging certain nurses, and you don't pay for the infrastructure of a hospital. And the quality, and a lot of randomized research studies have been shown to be the same or actually better.
And Brian, this is a pilot program we're doing now. How is this playing with your emergency medicine colleagues?
Yeah, this has been actually a program that's been opened with welcome arms, and I hope that this is not just a pilot, but will become a program. And the patients who are taken care of in the emergency department are ideally, who are qualified, will get sent home at the home hospital, and even our observation unit providers will send home to the patients home to the home hospital after a brief stabilization period.
Great. Luis and Brian, I want to thank you very much for everything you're doing to provide the very best care to our patients. I'm Tom Lynch, and that's Two Things.